Clinical problem solvers. Today we're going to talk about Cauda equina syndrome. By the end of this 4-minute video, through understanding, you'll be able to recognize this syndrome early, allowing for the best possible result for your patients. We got to start at its name, Cauda equine. Cauda, tail, equine, horse. Why does it have such a name? Let's look at the neuroanatomy. The spinal cord ends at L1 vertebra, and then after L1, what ends up happening is you get this nice, beautiful bundle of nerve roots, L2 through L5, S1 through S5, and the coccygeal nerve. What do these nerve roots look like? They literally look like the horse's tail, Cauda equine. In order to understand the syndrome, we got to know what are the function of these nerve roots. And of course, they're supplying the lower abdomen, lower extremities, bladder, bowel, and sexual organs. So we know Cauda equina syndrome is going to be a mix of motor, sensory, and autonomic dysfunction. Here's a select number of these nerve roots that you need to recognize that will help you understand Cauda equina syndrome. S2 through S4. This is providing the sensory input to the inner thighs, posterior buttocks, and the perineum. Literally, picture yourself on the saddle of the horse. So we're keeping in line with the theme of the horse. And I would say Cauda equina syndrome is really a tale of a horse to remember the condition. So this is providing the sensory input to the saddle region, but also it carries the parasympathetic fibers that lead to bowel contraction, bladder contraction, and even controls the anal sphincter tone. That's important to remember. L4, knee reflex, S1, ankle reflex. So now that we know these functions, let us talk about the Cauda equina syndrome. The most common symptom is lower back pain that radiates, because Cauda equina syndrome is literally pathology of nerve roots. What do we call that? Radiculopathy. Multiple nerve roots, polyradiculopathy. Radic stands for root. So Cauda equina syndrome is a type of polyradiculopathy. So back pain radiates downward. Another very common symptom in the majority of patients with Cauda equina syndrome is saddle anesthesia, because you're affecting S2 through S4. These patients also tend to have weakness of the bilateral lower extremity. They can have hyporeflexia of the knee, of the ankle, if L4 and S1 are involved. And this is one way you distinguish Cauda equina syndrome from a spinal cord pathology. Look, they're both in the spinal canal, but this is nerve roots, peripheral nervous system, not cord, central nervous system. So when the cord is involved, you get upper motor neuron signs like hyperreflexia, upgoing toes on Babinski, clonus. But when the roots are involved, that's when you get hyporeflexia. Both cord and roots can give bowel bladder symptoms. It can be a little difficult to tease these out, because when you have acute spinal process, you do initially have hyporeflexia. So as far as the syndrome, I think the most important thing to recognize, the majority will have back pain that radiates downward, majority will have saddle anesthesia, then you'll have some degree of weakness, bowel bladder issues, and sexual dysfunction. Why the bowel and bladder? Because the parasympathetic fibers, if they're not contracting the bladder, you get urinary retention that can lead to overflow incontinence. If you're not contracting the rectum, you get constipation. If you're not contracting that anal sphincter tone, you can get stool incontinence. It can be tricky to diagnose this because patients may not have all of these findings, and they may have asymmetric findings, but that is Cauda equina syndrome. As far as the etiology, we have to incorporate tempo because it's queen in our clinical reasoning. Hyperacute, think disc herniation, which is the most common cause of Cauda equina syndrome, or vertebral collapse or epidural hematoma. Acute, think more in the world of infection, like an epidural abscess from staph, tuberculosis as another example, or an inflammatory process like sarcoidosis. Subacute, think more the world of neoplasm, from primary neoplasm to metastatic disease that's compressing or lymphoma that's compressing, to metastatic disease that's causing leptomeningeal disease, so involving the pia arachnoid. You can definitely get Cauda equina syndrome by involving the leptomeninges. Now, as far as how do we actually diagnose this, when you're suspicious of this, the patient needs a SAT MRI of the lumbosacral region. But if you think that there's something other than disc herniation, you want to add gadolinium so you can evaluate for those inflammatory processes that we discussed, from infection, cancer, and sarcoidosis. And sometimes you might even have to do an MRA to evaluate the flow to the Cauda equina. Now, if the MRI is negative for something structural like a disc herniation or just shows enhancement at the nerve root, you're probably going to follow that up with an LP evaluating for those conditions. Cauda equina syndrome is a syndrome of the horse's tail, nerve roots, hyporeflexia, bowel bladder symptoms, back pain, saddle anesthesia, back pain that's radicular. First branch point, MRI, looking for a structural process, but be open to an inflammatory process or inflammation that's involving their nerve roots leading to Cauda equina. Can be a neurosurgical emergency, because if it truly is a structural etiology, then they need stat decompression. Otherwise, you target the underlying pathology.